Okay, well, good afternoon and good evening, everyone, wherever you are. If someone could just put in the chat that you can hear and see me okay and see a microscope slide on the screen, that would that'd be good. Then I know that I'm on the right page. So I know Ava has said that we're live, but if someone from the audience could indicate that as well, then we'll start. Okay, well, I'll assume we're live. Right, so the first case I'm going to show is quite interesting, actually. I don't see this very often. We're going to go through heme cases today, particularly trophines. I've had a busy few weeks on trophines, so we've got a large number of interesting cases. So the first one is a 63-year-old man. He presented with declining renal function, a renal biopsy suspected amyloidosis. He had a kappa to lambda excess. So his kappa was 815, his lambda was 30, so got approximately nearly 30 times ratio, 27-to-1 ratio. And this is his biopsy. So it's a decent, you can all remember how I look at these. So we've got a decent core of marrow, bit of blood at the end. Difficult to assess the cellularity on this at this power. Also, the bones are, I think, focally eroded, a little thin in places. I hope you can see the cursor moving. Ava, is the cursor moving okay over the marrow?
I don't see it on my side.
Okay.
Oh,
Can
now
you
I see
see it
it.
now?
Yes.
Okay. So I have to have it within that screen. Okay, so the bones are a little bit fragmented and a little bit thin, but you'd expect that of his age, and also he does have declining renal function, so he may have a degree of renal failure setting in and affecting his bones. And in terms of the marrow spaces, I think that for someone of this age, there's mild hypercellularity. The interesting thing, I think, in this one in particular, is all this material in the background. So we've got all this material here, which looks a bit like plasma maybe, or edema fluid. When we look at it at higher power, and it's difficult to get the color balances right sometimes. So we've got this pink eosinophilic material in the background, which is pretty much everywhere. And at higher power, it's really quite, it's amorphous, but relatively dense. And I don't think it's edema fluid, this material in the background here. We do also have quite a large number of atypical cells, and scooting over the biopsy, we've got some large cells of prominent nucleoli. Obviously got preserved erythroid islands. We've got preserved myelopoiesis, some neutrophils here. We have got preserved megakaryopoiesis. Here's some megakaryocytes. And if I just go around, so the query is myeloma or plasma cell dyscrasia. We've got large numbers of these fairly indistinct, large atypical cells, and then this amorphous background. Has anyone got any ideas about this background material? You don't usually see it to this degree. Well, certainly we don't anyway. There's some atypical plasma cells there for sure. Okay, no suggestions? Okay, well, first of all, I guess you want to know what the plasma cell burden is in this case. So for that, we did a CD138 and also a MUM1. And we tend to do both of them. The 138 tends to overestimate. The MUM1 is probably a more reliable figure, but sometimes it can underestimate. But certainly it's closer to the truth. So here we have CD138, and you can see here CD138 is positive in large numbers of plasma cells, many of which are in fact quite large. As we saw, large numbers of slightly atypical cells, and also there's this very quite dense background staining everywhere here. which I've not seen before actually. I'm just going to just check something about that. So I'm not quite sure why we've got so much background staining. CD138 should only really stain plasma cells and not much else, but we have got a large amount, I think, of immunoglobulin present between the cells that's been secreted by the plasma cells in this instance. So that's CD138, and we estimated the percentage at about, these are all current cases, at about 10%. Okay, so when you're looking at CD138, you're looking at these densely staining cells. It often overestimates when you use a 138 because the 138 is membrane, so it expands what the cell looks like, so it looks larger to your eye. MUM1 is a nuclear stain, and that's a more reliable indicator of the percentage. And I think that you'd agree the percentage here is about 10% overall. It's important in a marrow to look over the whole thing because you can have areas of greater percentage and areas of lower percentage. You want to have an idea of the overall, and then if there is strong variation, to say maybe that one area approaches 100%, so it might be say 5% overall, but there may be an area where it approaches 50 or more percent. The percentage used for the calculation as to whether it's myeloma or multiple myeloma, i.e. over 60% plasma cells, that's an overall percentage. But if you've got areas with increased percentage, it does mean that clinically it might be behaving more aggressively. And of course, a marrow sample is a relatively small sample of the whole marrow. And so if you see, if the overall percentage is relatively low, but there are higher areas in places, it indicates to the clinician that the overall burden in the bone marrow might be higher than is apparent on the bone marrow sample they've given you. I see Calvin. Thank you for your answer. Yes, I do think it's amyloid actually, and I'll come to that in a minute. So if I just show you the kappa and lambda before we go to the Congo red stain, we've trialed both Congo red and Sirius red histochemistry for amyloid, and we've found that Congo red is more reliable. So we do that. We've dropped our Sirius red. So this is the kappa. So you can see strong staining, both in this interstitial matrix between the cells and also within the plasma cells. There's strong staining within the plasma cells. And by contrast, the lambda, which will always stain some cells, is staining a few cells, and obviously there is a little bit of lambda staining as well because the normal bone marrow will have normal serum in it and that will have lambda light chains in it. But obviously there's an overwhelming excess of kappa, reflecting that kappa lambda ratio that was present clinically. Now this is the Congo red. So we have an institution in the UK called the National Amyloidosis Centre, and cases of suspected amyloid we send to them. They type it by immunohistochemistry. We use histochemical stains. To show you the control. It's always important with amyloid to look at the control so you know what you're looking for. If I can find it here, just bear with me a moment. They don't always put it in the same place on the slide. Right, so this is the control. So we have this nicely eosinophilic material, and of course control is very strongly positive. So you have to bear in mind that when you see something in your test, it might not be as positive as the control, but certainly that's what we're looking for, this kind of pale red pink material. So within the bone marrow, and this is a good example here. So the material in general is pale pink, and in places it condenses here around a blood vessel, and it's got stronger pink staining. And this matrix material has got this slight pink tinge. It's Congo red positive throughout the marrow. So when I've polarized it, it's only those small areas around blood vessels where it's stronger, such as here, which show green birefringence. But I think that by association, all of this material here is amyloid. It's just a bit pale, so it's not showing up under polarized light. But I think that this patient's making a lot of amyloid. There's also a bit of eosinophilia as well. So the diagnosis here is one of multiple myeloma. The plasma cell percentage is relatively low, but because they have got end organ damage in the form of amyloid deposition, then that turns it into multiple myeloma. So I think that's an interesting case. We don't usually see positive amyloid in the bone marrow, and certainly not of that degree. Basically, it's everywhere within this marrow, and that's certainly an unusual finding. There's another blood vessel where you've got it stronger around the blood vessel, but certainly lots of amyloid elsewhere. So that was a case from today. Okay, I have to keep them separately because some of them I've reported and some of them are old cases. So I think I'll go to the next case from today. Again, they've all got something interesting to say, these biopsies. So this next one is from a 58-year-old man who's presented with high white cell count. So he's presented with a hemoglobin of 104, white cells of 34.2, thrombocytopenic, platelets 45, neutrophils 0.6, and lymphocytes in the blood are 30.1. So the biopsy, you could say it's a little bit inadequate, but I think that it is adequate for diagnostic purposes. I don't know why why is that not showing on the screen? It should be showing on the screen. I can see it down the microscope. So why is it not showing on the screen? There it is. Okay. Okay. Because I moved to another thing, right? Okay, so it's certainly got lots of cause of blood clot, and usually we would not pay much attention to those, and we would say that they are inadequate. But we have got an adequate core of bone marrow down at the bottom. It's interesting that it is, for someone of age 58, it could be that it's subcortical. Obviously, we've got cortical bone here. There's going to be subcortical. So it could be that this whole area along here is a shave through the subcortical area, where the cellularity of the bone is always less than normal. But even at this power, you can see we have got collections of cells, which even at this power look quite dense. Going to slightly higher power on the blood clot as well. We can see that within the blood clot, we've also got large numbers of these small, round, dark cells. So we would normally expect to see a greater number of cells within the bone marrow, but we have them certainly enough in the bone marrow, but also lots in the blood clot as well. I wouldn't normally comment on the blood clot, but in this instance, because they look the same as the marrow, and we haven't got that many in the marrow, I'll give some attention to the blood clot as well. So coming back to that marrow section, this is a nice example of those cells, and you can see they're quite dense and dark. So they've got strong, kind of like dense chromatin staining, indistinct nucleoli, scanty cytoplasm, and there's really no other cell types present. So there's no normal erythropoiesis, no myelopoiesis, no macropoiesis, just these cells here. So the question is, what is this? I mean, it's unusual that you get this infiltrate of, clearly these are blast cells, dense infiltrates of blast, but the marrow is otherwise kind of hypocellular around it. But I think that's a consequence of it being subcortical, this area usually being quite empty. Subcortical bone is usually rather empty, and we've just got this spilling in. And probably as you go out into the marrow spaces, if they'd been represented in this biopsy properly, we'd have seen greater numbers of these cells elsewhere in the biopsy. Any takers for what this might be? So quite monomorphic population of small to medium-sized blasts, I'll give you that, and no normal hematopoiesis. Okay, so lymphoma is a definite possibility. Thank you, Pilar. I think the difference with lymphoma is that lymphoma is usually associated, even if it's quite extensive, with some residual hematopoietic tissue. So quite often you might see a boundary line between an area of lymphoma in a marrow and then some reactive adjacent hematopoiesis. So lymphoma kind of replaces the marrow by infiltrating it and expanding within it, but then pushing against the adjacent bone marrow. The alternative, thank you, Yan Jun, but there's good learning opportunity, and it reminds me to give some clues, is that an acute leukemia, that affects the bone marrow itself. So that's why it leads to a wipeout generally of normal hematopoiesis, because it's not just that the normal hematopoiesis is pushed away, but part of the hematopoietic process has been damaged, so you don't get normal hematopoiesis. And I think that this is an acute leukemia. So to say whether it's acute myeloid or acute lymphoblastic is pretty much impossible on H&E. I think the things in favour of lymphoblastic are the fact that the cells are more uniform, but lymphoblastic tends to have more prominent nucleoli, and a bit more clear chromatin in general. This doesn't. This is very dense chromatin and indistinct nucleoli. But acute myeloid leukemia, the cells tend to be a bit more variable, and acute lymphoblastic, they tend to be more variable. Well, we can look at the immunos, and then we can see what it is. And what I'll do from this is I will jump to a case of lymphoma to show how lymphoma has that boundary effect. So this is myeloperoxidase. Actually, that's within the blood clot. Let me just find the marrow. The marrow section is down there. Okay. So myeloperoxidase is negative. We've got maybe one cell there, and that's it. In contrast, if we look at CD20, for instance, I know it's not terribly good sample after immuno, but this is the CD20, which is strongly positive. It's also positive for CD79A, so we do have a wide range of markers. So that's 79A actually in the blood clot. I'm always a bit cautious about interpreting immunohistochemistry in blood clot because you can get artifactual positivity, but there it is within the marrow. And you can see that if you remember the other one, not all the cells were positive for CD20 because CD20 is a more mature marker. The CD79A, which is a less mature marker. So all the cells are positive for the less mature marker. And there is a range of differentiation within the tumour because some of the cells are negative for CD20, but most of them are positive. They're also positive for CD10, which is here. For TDT, which is a marker of lymphoblastic differentiation, strongly positive there. And weakly for CD19. They're also positive for PAX5, which is a B cell marker. So we have got T. So this is CD19. So this is really quite weak. And the reason why this is important, CD19, is we do CAR T treatment for CD19 positivity. So these patients often go on to CAR T treatment, and what they want to see is they want to see complete abolition of the CD19. So I think that is a case of B lymphoblastic lymphoma. Sorry, B lymphoblastic leukemia. B lymphoblastic leukemia. So if I go to a case of lymphoma, we have some, I think, through here to show the difference. Not that one. Not that one. Not that one. Oh, I know which it is. It's one of these. Right, it's not the best example because that's completely filled it, actually. It can happen. Right, so this patient here, yeah, there's a good example. Right, so this is more normally what we see. So this patient, born in 1946, so that makes him 80. He's got CLL and he's on active monitoring, but he's developed thrombocytopenia and neutropenia. So his neutrophil is 0.9, platelets 45. So they're questioning why that's the case, whether he's developing transformation. So here, I think even in this field, it shows it nicely. What we've got is we've got a patch here of CLL, and then we've got some normal hematopoiesis right next to it. So that's normally what you see with a lymphoma. I know it's called acute chronic lymphocytic leukemia, but it kind of tends to behave like a lymphoma in the marrow. So here we've got some residual normal hematopoiesis, and then quite a strong line, and there we've got the CLL. So that's more normally what we see. So if you see something with this clear distinction between some reactive hematopoiesis, here we've got erythroid cells, an atypical megakaryocyte, we've got some neutrophils in there as well, and then a clear distinction, a clear line along there, and then into the tumour or infiltrating lymphoid cells, then that is more likely to be a lymphoma. Sorry, Jan Yuan, coming back to your question, would you do a CD79A first? I think, in fact, if you were forced to choose one or the other, yes, I probably would go for a 79A, because that's going to be positive in pretty much all B lymphoblastic leukemias, whereas 20 can be negative in a proportion of B lymphoblastic leukemias, for sure. That was Clark. Just Clark. Okay, so that was a case of BALL, and then to show you by comparison a case of CLL. Now this case is a little tricky actually, but I think it's instructive given that we've just looked at a case of BALL. This is, so there's a 61-year-old man who has had a history of BALL and is now treated. And this is a question as to whether there is BALL present in his marrow. Sometimes these have a molecular marker such as Philadelphia chromosome, which makes it a bit easier to assess remission. Sometimes they don't. So this is his marrow. Again, there's quite a lot of pink material, like the last one, like the first one we looked at, but I think in this instance the pink material is edema fluid secondary to chemotherapy. There's also quite a lot, I mean that's a dilated vascular space, but there's also quite a lot of artifactual hemorrhage within it as well, and there's large amounts of small dark cells. So looking at them in higher power, I think you can see even at this power, and certainly at this power, that they're variable. So we have got some kind of isolated erythroid cells on their own, these small dark cells. We've got some neutrophils, some eosinophils, more neutrophils. There's very little in the way of megakaryopoiesis actually. Megakaryopoiesis after chemotherapy can be one of the later lineages to come back. But I think that overall, these appearances, very jumbled up pattern of cells, which you often get in regeneration. The cells are just wildly regenerating, usually under the response to growth factors. But doesn't look like there's any blasts here. But to check it with immunos, obviously we've got flow cytometry as well. So CD10 is a marker of lymphoblasts amongst other things, and this is the CD10. So the CD10 stains the vascular channels, but there's also quite a lot of these positive cells. Okay, so that in itself is a bit of a worry as to whether there's low-grade residual disease, but we could look at those cells in more detail. The initial cells, the presentation biopsy was positive for CD10 and for CD34. So we know that CD10 is positive, but if we look at CD34, we see that it's virtually negative. We've got maybe one cell positive there, maybe one cell positive there. So less than 1% of the cells positive for CD34. All this positivity is vascular channels. So there is a population of cells positive for CD10, but they're negative for CD34. And that population of cells, a proportion of them, but not all, is positive for CD79A. And this is a nice example here. You've got slightly atypical cell there, and you've got a plasma cell here. So the plasma cells we can ignore. We're interested in these cells here. Again, these would be less than 1% of the overall cells. Strongly positive for 79A, whereas we know that the presentation biopsy was only weakly positive for 79A. These slightly atypical cells that are in the background, and some of them are positive for CD10, they're also focally positive for TDT. So nuclear stain right here and here and here, but they're very low numbers. Whereas the presentation biopsy, again, more TDT positives here, the presentation biopsy was negative for TDT. And finally, they're also positive for PAX5. Of course, PAX5 is a B cell marker. My interpretation of this is that these slightly atypical cells are not lymphoblasts. They're not positive for 34, which the initial one was, and they are positive for TDT, which the initial one was not. What we're seeing increasingly, particularly with a lot of use of growth factors after treatment, is hematogones, which are very immature precursor cells, which otherwise share some of the features of a lymphoblastic phenotype. So they will be positive for CD10, for CD79A, for TDT, and for PAX5. In this instance, even if these occasional cells were blasts, they're not of significance because they're less than 1%. So this is remission, essentially. And the patient has undergone initial chemotherapy, and then they will probably go into some kind of trial, either for CAR T treatment or for a transplant. So all the clinicians want to do is get the percentage down really low, which they'll have done. But it's more likely, particularly with all those CD10 positive cells, of which there are a lot, that these are all hematogones, that they're being driven by the growth factors. So in the early days when we started seeing these hematogones, we got a bit confused, but now we tend to ignore them. And of course, this patient will also go on to have cytogenetics and molecular testing for BCR-ABL, because the initial tumor was BCR-ABL positive. I don't know what the result. I don't know if we have the molecular result for that yet. Actually, let me just see if I can. Oh, I can't find it. I can't find it easily. I'm sorry. I will go back. Okay. So I think these are hematogones in this instance. But got to be very careful with clinical correlation and use of other factors to establish that. Let me just see, actually, because I'm sure you're as intrigued as me now as to whether there is a BCR-ABL result for that patient yet. It may be that there is already, because they do it quite quickly. You just wait, 1 minute. And if nothing else, that emphasizes the multidisciplinary approach of Haempath. Fortunately, we've got an integrated reporting system. We're able to see all the tests under one umbrella. Yeah, the cytogenetics is back, in fact. And there's no evidence of a BCR-ABL gene mutation. Okay, so BCR-ABL was negative on fish cytogenetics. So that really emphasizes the fact that this is remission. Okay, so I've done that one, done that one. Now I've got two other intriguing cases. One myelofibrosis and one chronic myelomonocytic leukemia. each of which has got some unusual features. Give me all the unusual ones today. I hope this is proving useful. I think it's good, particularly in this, more specialized hemopath audience, to show some more difficult cases from time to time and show my thought process through them. So if anyone, are people happy with this approach or not? If you just get some feedback from the chat, that's helpful for me. Otherwise, it's difficult speaking into a vacuum for an hour. Okay, thanks very much, Rosemary. It's a bit like being on the radio. Please phone in, as they say. Okay, so the next one is a man born in 1962, so he's 60, just coming up for 64, 63 at the moment. His hemoglobin is 119, his platelets 154, his white cells 5.1, and his neutrophils are 3.4. So he's mildly anemic, platelets just about normal. He developed secondary myelofibrosis. He started off in life having polycythemia vera, then developed secondary myelofibrosis about 2 years ago. He's got a JAK2 mutation, and now he's on the FEDORA trial for myelofibrosis. I'll just tell you quickly a bit about the FEDORA trial. So it's a combination of an antibody, fedratinib, combined with an interferon. So it's an anti-megakaryocyte antibody combined with this interferon. So it's ropegin interferon, which is a pegylated interferon, and fedratinib is a selected JAK2 inhibitor. Okay, so the two in combination are being used. So a JAK2 inhibitor and interferon to potentiate the activity of that inhibitor. I said it was an anti-megakaryocyte, but obviously, it will be in this case because it's JAK2 positive. Right. So what we have here is the marrow. This is really quite interesting. So the patient's got myelofibrosis. They've not been treated with myeloablative therapy. They've not been treated with chemotherapy. They've not been treated with a transplant or anything like that. They've been treated with this JAK2 inhibitor and interferon. The marrow is almost maximally hypercellular. The other thing about it is the bones. So the bones here are, I would say, of normal thickness for someone of this age. Certainly they're not sclerotic, which is what you normally get in myelofibrosis. Even that, you'd be hard pressed to put that area as sclerotic. The other thing to note is the reticulin. So the reticulin in myelofibrosis should be at least grade 2 and usually grade 3. And here's the reticulin. So we counterstain our reticulin with a trichrome. So collagen is stained purple. There's a bit of periosteum as a kind of internal control. Moving out into the marrow spaces, we have got increased reticulin, but it's not grade 3, which is what you usually get in myelofibrosis. I'd say this is grade 1 to 2. I think I've called it 1 to 2. Yeah. So grade 1 in the WHO classification is a network of fine fibers. And I would say that this here is a network of fine fibers. We also have occasional coarse fibers, such as here. And there's no grade 3. So mostly, quite a lot of it is grade 1. This is not collagen fibrosis because that's around a blood vessel, another internal control. There's a blood vessel there. You've got to ignore that where it's around a blood vessel. So I think that we've got mainly 1 and some 2, but the bone features and the reticulum features would not amount to myelofibrosis. However, if we look at the cells themselves in detail, if I can find it, yes, here we have it. Okay, so I think that this is a good area here. We've got marked myelopoiesis, marked erythropoiesis, and also very marked megakaryopoiesis. So here we've got some disrupted erythroid cells, like that's erythroid, that's erythroid, that's erythroid, lots of neutrophils and myeloid cells in the background, and these large, irregular, and dislobated, hyperlobated megakaryocytes. So we've got a lot of megakaryocytic clustering present still. There's another megakaryocytic cluster. Almost everywhere you look, the megakaryocytic cluster is another one, more through here. So we've got an asynchrony here between persistence of megakaryocytic abnormalities, but absence of bone-related or reticulin-related abnormalities. And the bone and reticulin related abnormalities driven by the production of platelet-derived growth factor, fibroblastic growth factor, secreted by megakaryocytes, and that's what causes the fibrosis. What we have also is marked erythropoiesis and myelopoiesis, which is reflected in a near normal hemoglobin and certainly a normal white cell and neutrophil count. So I'm not an expert on the histopath features in the FITORA trial, but it looks like it restores erythropoiesis and myelopoiesis. It reduces the myelofibrosis. Yeah, so one of the endpoints of the trial is to see if it reduces the fibrosis. So that's one of the things it mainly does, is reducing the fibrosis. So it's not getting rid of the disease, which is why you still have these atypical megakaryocytes, but it's reducing their effect on the bone marrow, in particular reducing the fibrosis and allowing normal hematopoiesis to return. One of the reasons why you get reduced effective hematopoiesis in myelofibrosis is obviously the scarring and fibrosis within the marrow, and that's also what makes transplanting bone marrows people with myelofibrosis quite difficult, because if there's residual increased reticulin and fibrosis within the marrow, it makes it much harder for the transplant to engraft. So I think in this instance, what's happening is that the drug is inhibiting the fibrotic and scarring effects of the myelofibrosis. It's not eliminating it because it's just an inhibitor of the JAK2. So the abnormal megakaryocytes are remaining, but the marrow is able to have a return of normal hematopoiesis as the scarring is reduced. So I think really interesting case, actually, and I learned a lot from that. It's always good to learn something new every day. It's what keeps you on your toes, keeps you interested in pathology, life in general. We are fortunate in being in a field where things are constantly evolving and we're constantly learning new things almost every day. Right, I think we've got, so the next one is another trial, actually. This is another really interesting case. So, and this one must leave on a note of confessing my ignorance. It's always good to know one's limits. That's where you learn. So this is a man born in 1950, so he's 75 at the moment. He's had chronic myelomonocytic leukemia. We see lots of these because one of the national experts happens to be in a hospital that we work with very closely just down the road. So he's had CML, chronic myelomonocytic leukemia 1 since January 2022. He progressed to CMML 2 with 12% blasts in August 2022. He started the AMMO trial in 2023, and the AMMO trial is a combination trial. It's a combination trial of a new drug, which is decitabine. So it's a combination of decitabine and cedaridine as a new combination chemotherapy. These are hypomethylating drugs. Anyway, cut a long story short, and that's that national trial is being led by one of my colleagues at the Christie Hospital. Daniel Wiseman. Right. It's not a very big biopsy, but again, this is something. And I think the other really interesting thing about haematopathology is we see a lot of begin to see a lot of trial effects, which we wouldn't normally have seen. I mentioned already the hematogones that we never used to see in. We never used to see hematogones until we started doing these more elaborate transplants and kind of supportive care therapy for patients. Now we've seen them a lot. And then we've seen the effects of the Fedora trial in myelofibrosis. And now I think this may be the effects of the AMMO trial in chronic myelomonocytic leukemia. So it's not a great biopsy because a lot of it's periosteum and fat, but we do have representative material either here, and I do have to stop on the hour because I have a clinical meeting to go to. So I will speed up slightly. So definitely we have got some restoration of some erythropoiesis, some myelopoiesis, but we've also got tons and tons of megakaryocytes. So if I show you the immunos quickly, you'll get an impression of the relative abundance of the different lineages. And usually chronic myelomonocytic leukemia is an increase in myelopoiesis predominantly, though you can get an increase in megakaryopoiesis. So this is myeloperoxidase, and you can see there's a fair number, but definitely a reduced number of myeloid cells. Next, E-cadherin, which is a good erythroid marker, and basically there's not a lot of erythroid. And my surprise was when I looked at CD61, which is a megakaryocytic marker, and basically it's full. It's full of megakaryocytes there. And then the other part of the specimen, which if I go back and show the H&E again quickly, it's difficult to appreciate what is in that other section because there's not much else apart from this pale material. But if you look in the pale material in a bit more detail, you'll see that some of these are actually megakaryocytes in the H&E. And on the CD61, whoops, it's just completely packed. Now, I don't know if pre-trial this patient was someone with a particularly high number of megakaryocytes or whether this is a trial effect. It could be that this is a trial effect with expansion of the megakaryocytes as the other lineages decrease. I don't know. I can update you because I will ask my colleagues, and I will remember to let you know when we next speak. So went through some more atypical cases today, really, showing you the range of what we have to deal with and how we can learn from every case. So try to learn something new from every case. When I started haematopathology I didn't know anything about it. I was given a book by the consultant and said, Richard, here's a book. It's not that difficult. And he walked out of the room. I've spent my entire career learning from every single clinical case as much as I can. And hopefully I've learnt more than I started with. So never stop learning. Are there any questions or comments in the chat? Next week, it is back to lung pathology. Dr. Angelis Monteres from Liverpool is a regional expert in lung pathology. So she'll be talking on an aspect of lung pathology. She will be an excellent speaker. And the week after that is Ruth Green talking on skin pathology. So you'll have a break from me for 2 weeks, and then I'm afraid you'll have me back for 2 weeks. So are there any comments before I sign off? And thank you very much again to Ava and our colleagues at Diagnexia for excellent teaching. Ava will be with us for the next few weeks, and then her colleague Charlie will be taking over. Ava will be moving to a different administrative role. She's very, very ably supported the program, kept me on my toes and everyone in line recently. Okay, so Pilar, we don't use IHC for amyloid. The reason is we send it to the national. We're obliged to send it to the National Amyloidosis Centre, which is the national referral centre for these cases, both for clinical treatment and also for diagnosis. So we kind of like say we think this is amyloid, and then they will go on and do the immuno. So we don't do it in house. No. Any other questions? Can we do case series? Okay, so what do you mean, Rosemary, by case series? Yeah, so we can do molecular testing in bone marrows after decalcification, but you have to be careful about the decalcification. If you use formic acid, you can't. If you use EDTA decalcification, then you can. There are other less stringent decalcification protocols that will allow you to do molecular, but it usually has to be slower decal and a gentler process. So Rosemary, please, just what do you mean by the case series in hematopathology? So that will direct me for the future. Alternatively, if I type my email in, okay, so cases in categories. So Rosemary, yes, we can do that. I've tended to go with a more fluid approach because that suits my teaching more easily because I teach every fortnight, so it's quite a lot of stuff to get together. I could start putting together I could start going through things in a more ordered fashion. Certainly, I've got teaching material to allow that. Can I just have a vote then, please? For the next session, would people like me to continue with cases that have come across my desk or a more structured approach? Just say structured or unstructured in your reply to the chat, and we'll see what people say, please. Structured from Rosemary, of course. Okay, I've got 2 for structured. Okay, I will from now on take a more structured approach to the Haempath training once again. I think this Haempath training has evolved because I did a structured approach probably a couple of years ago when we had new people, and now, and of course we've got new people now who have not benefited from that. So I will now go through a structured approach, starting with reactive and working my way through all the different types of Trefine pathology. Okay, it's now the hour, so I have to get back to my clinical meeting. Thank you very much, everyone, for your attention, wherever you are in the world. I'll close the session now. Okay, I suspect a case. Okay, Pilar. I think the best thing is to look at, the immuno profiles online. I'm not a general. I don't do general anymore, so I'm afraid I can't help you with that question. Okay, come in. So good morning, good evening, and good night. I'll see you all next week.